Hello, and welcome to the Pulse of Manatee, brought to you exclusively on METV. I'm your host, Dr. Srini Iyengar, a cardiologist at the Braden Cardiology Center. Let's start today's show off with a startling statistic. The Center for Disease Control reports that nearly 26 million Americans have diabetes, and that 7 million Americans don't even know that they have the disease. In today's show, we want to discuss the very serious complications of diabetes and provide tips on prevention. With the correct treatment and lifestyle changes, many people with diabetes are able to prevent or delay the onset of complications. Let me introduce our guest today. To my left, we have Dr. Ray Rates, a family practitioner from North River Family Health Center. We have podiatrist Dr. Alyssa Zanchevitz is also joining us today, as well as Paula Jefferson, who is a registered nurse and the director of the Heart and Vascular Center at Manatee Memorial Hospital. In addition, we have Dr. Celestino Palomino, a nephrologist who is with Manatee Kidney Disease Consultants. Thank you all for being here, and folks, let's get started here about this great topic today because, as I previously mentioned, diabetes, what a prevalent condition in today's population. So Ray, I'm going to start off with you at this point because I know that you have a very busy practice and you see a lot of these types of patients. So let's put a example out there, or a hypothetical situation. A patient walks into your office with some blood tests in their hand and they have a blood sugar that is over 150. What would you do with that patient right off the bat?
This is the typical patient, but there's a lot of others that come in who have progressively rising sugar over time. The real problem I have is this. I have to tell this person who has no symptoms, who feels great, who has memories of family and friends who have diabetes and all the horror stories that they have a disease. They don't want to hear it.
And it's pretty amazing. I have to agree with you because when I see patients oftentimes when they feel good don't want treatment of any sort. They look at it as a number rather than actually a symptom. So it's kind of hard to convince patients that they need to be on medications when they feel they're doing pretty good actually.
And men are tougher than women, because men are raised from the time they're little boys to be macho and strong, nothing wrong with me, they're invincible, they played high school football, etc., and they don't want to be told anything is wrong with them. So now I have to tell them there's something wrong with you, it's not going to go away, it is going to be progressive maybe, it's going to maybe hurt you in times to come, you're going to have to take a medicine, you're going to have to take pills, maybe even one day a shot, and you don't want to hear that. Then you're used to a certain lifestyle. You're used to going out with the boys and having a beer after the ball game. You're used to eating something you shouldn't eat because it tastes good and the like. And so all of a sudden you have all these images that I can't do this, my life is over, but it's not. And the message I want to leave everyone with today, and I think everyone will correlate with that, is there's a lot you can do to have a great life.
And Alyssa, that's now going to your end of the spectrum here. Now as a podiatrist, a lot of times you'll see patients that have ulcerations on the feet, but they don't know why. They'll just say, hey, I stubbed my foot and it's not healing. And you'll see them and you'll find out, well, guess what? It's not just the ulcer, but there's something internal that's going on here. Now, how do you bring that topic up with them?
Oh, definitely. I feel your pain with some of these folks. You have to tell them that they have a problem, but they may not feel it due to a condition called neuropathy, and that's a tough word to put together for people out there. I explain it to people as the nerves go haywire. High blood sugars cause damage to the very small nerves and blood vessels, and the nerves don't know what to do. Nerves go everywhere. They go to your skin, they go to your muscles, they go to your blood vessels. When they go haywire, they send signals when they're not supposed to. Like, my feet are freezing. Dr. Z, oh my gosh, they're freezing. I'm putting heating pads on them. No, they're not. They're warm. Oh, they're burning. They're on fire. I'm getting these shooting pains. No, they're okay. I stepped on a nail. Isn't that crazy? I didn't even feel there was a nail in my shoe. So they're not sending the signal when they're supposed to. You have a nail in your shoe, but they're sending these crazy signals. So that's the best way to explain to them what neuropathy is. But if they don't feel that they have an ulcer that's down to the bone, how am I going to tactfully say, well, let's start from the basics. Let's make sure it's not infected. Let's check your glucose control. We're getting out of that flip-flop, okay? You really have to start at the basics and tell them step by step what they need. It's a lot of information for one person to take. And I just came from Dr. Rates, and he says I can't drink beer after the baseball game.
Well, the thing is, that's a great point too about the nail in the shoe, or the nail, or the pain in the foot that they don't feel, or the thing that old people who don't have diabetes, and this is something important for people at home to understand, that if there's an ulcer in the foot, or if there's some type of pain that they're not feeling, well, that could be a sign of a lot worse underlying condition. It's not just the ulceration that's there. So I think that's important to understand what you said, small vessel disease. And on that topic, I'm going to go to you, Tino. From the kidney perspective, diabetes is a systemic process. I think everyone at home has to understand what I mean by that. That means that it doesn't just affect sugar. Sugar affects all blood vessels, all parts of the body. And as a nephrologist, as a kidney specialist, what are you seeing now with these progressive diabetics?
Well, by the time the patient comes to me, they have a lot of end organ damage. In other words, they have multiple complications due to the diabetes. As a matter of fact, the largest percentage of people that are on dialysis are diabetics. The second largest is high blood pressure. But going back to the foot ulcer, it's a cascade of problems. The first thing that happens is that they have the neuropathy or their end nerve damage, no feeling. The ulcer comes in because they keep walking on a bad shoe or a nail, and they already have vascular problem, so healing is a big problem because they don't have enough circulation to that ulcer, so it's a systemic problem. The ulcer is the tip of the iceberg. It happened to get there because of neuropathy. It's not going to heal because of vascular problems. And again, like I said, the largest percentage of people that come to dialysis is because of diabetes. By the time they got there, they already have heart problems, vascular problems, neuropathy, so it's a cascade of problems. And a lot of it, let's not say it's preventable, but we can delay the onset. And we've done a very good job. As a matter of fact, not too long ago, and I'm not as old as Dr. Reyes here, it was a time when anybody had any indication of kidney problems because of diabetes. Within 5 years, that person would have been on dialysis, regardless of what's done. Now I see patients that are referred to my office with advanced kidney problems, and 10 years later, they're not doing great, but they're still there.
But they're still not on dialysis
Not
either.
on dialysis.
That's the important take-home message, that we can prevent the long-term changes, shall we say, in the kidneys by effective medical therapy. So that's a great point. And Paul, I'm going to go to you here now from a cardiovascular perspective. Now, what have you seen in the last, say, 15, 20 years with diabetics, and especially in their angiograms, coming from a perspective of radiology background? What do their arteries and vessels look like?
Radiographically, when you see a person that has diabetes, whether they know they have it or not, usually when you see it, when it comes up on the monitor, you can see the scrawny vessels, how small they are, and the nurses or the staff or the physicians will say, this patient's a diabetic. And the patients aren't aware that this disease affects them systemically, and it's an education with the family to let them know what this disease does to them, what they need to do, and how they can control that.
Well, so now that we've defined possibilities of ulcerations in the feet, cardiovascular disease, how they present in the office, and nephrology or renal disease, let's talk about more, how do we treat these patients now? Like, what is, other than the obviously medications or potentially insulin for patients, Ray, when you see these patients, and example, if they're overweight, if they have high blood pressure, cholesterol, how do you convince these patients that, listen, this is a multifactorial issue, there's a lot of things involved here, it's not just the blood sugar?
Well, first thing, it's really important to teach people that they can do something about it, and they can. The shows you see on TV, like How It's Made and How This Works, everyone likes those shows because they're about physiology. People want to know, when they put the gas pedal down in the car, it goes, but they really like to know, how does the engine work? They like to have a little technology. Everyone's into technology. So I think people need to understand that, and people are not afraid, by the way, anymore of education. People used to go to diabetic classes and think it's a class, they don't want to go. But they excited about it. Now, we have classes in our office every month. We can't keep people out. It's full. And people want to know, what can I do? So I like to teach people something. I like to teach them about the disease, a little technical stuff, but not bad, such as the main 3 reasons people have diabetes. We're taught in medical school. and they're still holding. And the first thing is that your body doesn't use insulin like it should, and so there are things we can do to correct that. The second thing that happens is your liver's producing all this extra sugar, and there's things we can do to help tone that down. And lastly, by the time, even when diagnosis is made, most of the pancreas is already affected, and some of the cells that produce insulin is not like it should be. So I like to teach people and get them involved in their care. I like them to know the causes of diabetes, what they can do to improve their insulin use, what they can do to decrease their carbohydrate and sugar production by the liver. Also, I like to teach them some technical things. We as doctors always follow this thing called an A1C. So it's in medical profession, it's called glycosylated hemoglobin, but we call it A1C.
And for everyone at home, that's just a simple blood test that's usually done if you are a diabetic, in addition to your basic lab values. So an A1C will be quite often a routine test that's done as well. Continue, Ray?
Right. And the A1C is so simple to explain. You have blood cells in your body, and what happens is these blood cells soak up sugar. The higher the sugar, the more they soak up in the membrane. The lower the sugar, the less. We can measure it. It doesn't even have to be a fasting test. And it gives the doctor a real good idea about what the level of control is. People, if they have education, can go forward. And the better that we can control the sugar, the better we can control the A1C, the less need you'll have for Tino here and Elise and the cardiac things like that, because if we can prevent disease, it's better to prevent a heart attack, wouldn't you say, than bailing someone out when they have
Melissa,
one.
I got a question though. Yes. Going from your side now, so you have a diabetic with this type of foot ulceration that you're treating right now. Now let's throw a little bit of another thing into the mix here. What if they're smokers? Now,
Oh boy.
Now, how does that affect?
There we go.
You're adding another huge issue. So I'd like to want you to comment on that.
Well, just in general, smoking and healing does not mix. I'm not sure, honestly, about the research with these new electric cigarettes, but I'll say that they're better than the Marlboros out there, okay? In general, any kind of healing, whether it's after an elective surgery or if you already have this chronic inflammatory process in a wound that's quite deep, that's going to slow down your healing. And then if you take a step back and go to the peripheral arterial disease, those small vessels that are already saturated in sugar that are going to be so hardened, those arteries aren't going to be able to heal the skin that's right there. And it has to do with the duration of the smoking as well. I've had some people fill out on their new patient form, smoking duration, they've said forever. Or some have said, some won't even say, they say 2 packs a day. And I have to get it out of them, like, okay, so you're 80, when did you start? 12, 14, just too much. So smoking is definitely a contributing factor. And to go back real quick about the A1C, research has shown that when it's 7% or higher, that's going to increase your chances of neuropathy, nephropathy, retinopathy, the eyes. Diabetes is the only disease that affects every system, every single system.
Absolutely.
Your skin, your kidneys, your circulation, your liver, your eyes, just...
Well, and the thing is, I have to say that people have to understand at home too that, like I said, it's often thought of as a sugar disease. But I think we have to really look at it as a systemic disease. Like, it's a vascular disease. It destroys organs, you name it, like you just said, your eyes, your kidneys, your heart, all the small vascular structure in your body. I think people have to realize that it's just not about, hey, well, my blood sugar is a little high, it should be okay, I should do fine. And another big contributing factor, if we talk about smoking, Tino, why don't you comment a little bit about blood pressure?
Oh. Actually, let me go back to the smoking, and you know well as a cardiologist that every vascular path, in other words, every patient that you see that has all kinds of vascular problems, 100% of the time is a smoker. You never see somebody really, really bad, including being diabetics, that are not smokers. So smoking is a tremendous contributing factor to vascular problems. The question was about
blood pressure. So because obviously that's something that you are a specialist in. So what would you
blood
say?
Blood pressure is extremely important. We just said that the largest percentage of people on dialysis are diabetics. Second, are hypertensive. Most of the diabetics are also hypertensive. So now you have 2 strikes going against the kidney. And going back to blood pressure, when I said that. Now, 5 years doesn't mean anything on these people. They can go on with diabetes and renal failure for much more longer than that. It has to do with the blood pressure control and the new medication that we have in the market, such as the ARBs and the ACE inhibitors, is to the point that I think that every diabetic, regardless of what the kidney function is, should be either on an ARB or an ACE inhibitors, because clearly it has a tremendous kidney protection benefits.
And these medication, ACE inhibitors and ARBs, are medications your physician can talk to you more about. They are blood pressure, normally used for blood pressure control, but they are, as Dr. Palomino just mentioned, very helpful in patients with early stage diabetes, even late stage diabetes for that matter.
On any, as a matter of fact, I'm not so sure that we need to wait until they have any kidney problems to start them on these medications. As long as you're diabetic, and let's face it, if you're diabetic and your diabetes is not well controlled, you will have all the complications that we're talking about. It's just going to happen within 10, 15 years, but it's going to happen. Even those that are well controlled are going to have some complications.
Amount of it.
We just want to retard the time that,
exactly.
that they're going to come.
Keep the longevity as much as you can with the kidneys.
I would like to add to what Tino's saying, because we're talking about medication at this point and how medications can prevent the disease and delay the disease, and in renal aspects actually improve kidney function. Tino has taken patients of mine who were on the edge of dialysis and brought them back to renal function that's really comparable and well. The American Diabetic Association tells me, as a family physician, everybody who has type 2 diabetes, everybody should be on 3 medicines from the get-go. They should be on an aspirin, they should be on a statin, like a pravastatin, a Lipitor, a Zocor, a Crestor, one of those. Statins exert enormous benefit not only on lowering the numbers, but on stabilizing the blood vessel. So aspirin, a statin, and finally these medicines that we call ACEs or ARBs that interrupt how the blood pressure effect is made to happen.
Now that's a very important point for everybody at home who's watching, that Dr. Race just mentioned, that the aspirin, because the fact is a baby aspirin a day really, in most situations I would say, unless you have something of a bleeding ulcer of any sort of bleeding issue, is actually a very, very good medication. The ACE inhibitors and ARBs, which we just discussed, are very good to be started early in the process, but the statins, so people have often said to me, if my cholesterol is not high, why are you starting me on this medication? Just like you just mentioned though, there's other effects of the statins beyond just cholesterol reduction.
We should start a patient on an ACE inhibitor with diabetes who does not have hypertension. It's that important.
Absolutely.
It's that important.
Why wait for the process to begin?
Right. The preventative things, let's face it, the American Diabetic Association and American Heart Association, I think you will attest this, says that diabetes is an equal risk to heart disease as though you have had a heart attack. So one heart attack, you're ready for more. Diabetes is equal to that. So we should be aggressive.
Absolutely agree.
The thing is, a lot of doctors sometimes and patients get caught up and say, well, these are just guidelines. They're more important. They are proven guidelines. They save your life. They save your lifestyle. They save your feet. They save your vessels. They prevent the disease. It's worth doing.
They save your
treatment
kidneys.
for heart disease in the cath lab. When you have these little scrawny vessels, it's very difficult to send this patient to bypass surgery because there's not enough vessel to do the bypass. So the interventional cardiologist like you, Dr. Iyengar, is in there trying to open these vessels and keep these open, and it's very difficult.
And it also goes with ulcerations. If they have diabetic vessels, those vessels don't necessarily respond to opening them up either because they're so tiny and scrawny.
It's what's called a microvascular disease, small vascular vessels. Sometimes the perfusion or the blood flow can be increased if there's a blockage. And of note, going back to the heart disease, your vessels in your heart are about the same size as that in your feet. It's the same reason they use the vein from your leg to put in your heart, and it's right next to the other arteries. So if your heart has been blocked, then your leg may have had a blockage. So if you've never been worked up for peripheral arterial disease, where you can take a simple test where you take a blood pressure of the ankle, you compare that to the arm, sometimes that's even higher than normal. It's calcified. That doesn't mean you're out of the woods. You can still have disease in both sides.
And that's a great point, Alyssa, because the thing is that everyone at home, I'd like to really emphasize that if you have peripheral arterial disease, you're about 5 times more likely to have a stroke or a heart attack. I think people feel that, well, I have an ulcer on my foot, why are you checking my heart out? Because of that exact point.
Or I have heart disease, why are you taking blood pressures of my ankles?
Right.
Yeah.
And going back to what you said, because your specialty is podiatry and keeping people walking, think of it, how do people exercise? Most people walk. It's very important. So as soon as we don't take care of our feet, then our exercise goes down. Our exercise, think of it, just walking will improve your mitochondria, those little furnaces in the cells that burn up the sugar, that lower the sugar, that help us to be better, and help us lives be better. So keeping the feet are not only a marker of the rest of the body, but they also help us to exercise, which reverses that insulin insensitivity. Now we use our insulin better.
Exactly. The sense of the body is much more efficient when it's an aerobic machine. The heart needs to be worked. The vascular system needs to be perfused. And on that point, Alyssa, why don't you show us some of those shoes that you have with you?
I'd be happy to. I did want to make a comment about walking and the denial that sometimes people are in with diabetes and the neuropathy. So it always comes into play. Dr. Iyengar told me I have to walk for circulation, but I just told them you have a wound that's on the bottom of your foot and I want you to stay off of it. It's always a fine balance to stay off of the foot now, but exercise later or work together, or maybe depending on the wound that's already healed, but I need you to be in a good shoe to prevent this problem. Medicare does pay 80% towards the allowable amount for one pair of shoes and 3 sets of custom molded inserts in people who meet the qualifications. Some people come in and say, Dr. Rates just told me I'm diabetic, I'm here for my shoes. Say, well, let's do a whole foot exam, and you do have to meet certain criteria, such as lack of protective sensation, pulses may be diminished or absent, calluses forming, foot deformities. So sometimes the good news is their feet are still doing pretty good. You caught it early. But the bad news is you'll have to go to maybe Sports Authority or New Balance or Fit to Run to get some new shoes, okay? So first of all, if you come in with this,
and we can get a close-up of that flip-flop here, the typical Florida flip-flop.
Oh, it's just lovely. It's very easy to hit people over the head with it, okay? Nope. However, this would be a little better suited for you. And for men, something like this. Medicare has very specific guidelines. You just can't go to the store and get a shoe. There are specific things they look for. This part is called the toe box. You want this nice and wide and deep for your toes that may have little hammer toes in there. You need a stiff sole that's not going to bend. Sometimes we can get them with laces so you don't look too old, but a little Velcro to help those hands there.
Alyssa, do we have a cost on some of these? Like, Medicare covers 80%. What's the total? Do you have any offhand?
Oh, a few hundred.
A few hundred, got it.
Yeah. But Medicare would rather, of course, they'd rather save your feet, because we haven't talked about the fact that 60% of all non-traumatic amputations are due to diabetes.
Unless the people who go to the sporting stores to buy basketball shoes, the nice basketball, they're spending pretty close to your $200.
Yeah, and it's better to put a few $100s ahead every year than maybe $100,000 for an extended hospital,ization and possibly an amputation. So for women, they're even fashionable.
And additionally, it's perspective. People will look at a shoe and say, oh, $100, and they complain about that, but they'll go out to eat and spend $100 or $50 or put $50 in their tank of their car without it blinking an eye.
Oh, sure.
Which is more important, your feet and your health, or
and you can get 3 sets of these sort of inserts. This is what's called a multi-density foam. And this particular foam on top, if I hold this for a few minutes, this will actually conform to the pressure of my finger. That, along with heat, will allow this to further conform to the foot to reduce the pressure points, because that's really the pathway to, unfortunately, an amputation. Neuropathy, loss of sensation, pressure, such as from a deformity, that can form a blister or a wound. That will be slow healing due to high blood sugars and microvascular disease. And that can go deeper, become infected, and ultimately, unfortunately, lead to amputation, if even it's a toe or part of the foot.
Well, listen, I think that's an amazingly thorough explanation, because I think people at home don't take it as serious as they should. That, I think, is a take-home point here, is just that literally a simple blister can eventually end up with something called osteomyelitis, which is an infection of the bone, which can end up in a potential amputation.
I've had patients that I followed. Unfortunately, I got them a little too late. It started with an ingrown toenail, and they ultimately ended up with the below-the-knee amputation.
Amazing.
From something that simple.
Tino.
One point I want to make, since you're here, and I have seen this many times, is how important diabetics and foot are. And they should not be taking care of the nails themselves. I have seen people losing their leg because the wife, the sister, the daughter cut their nails. They cut too deep, and infection sets in. They don't heal well because of all the complications that we talked about, and they end up with an amputation. So it's extremely important that they see a specialist once they know they're diabetics to take care of their
and
foot.
people should understand too that amputations are not a benign process. I mean, once an amputation begins, the quality of life and the mortality, or should we say the lifespan of patients who end up with with amputations, especially below the knee amputations, your quality of life deteriorates dramatically, as well as the lifespan of the patient.
Yeah, 50% chance of dying within 5 years of an amputation.
Exactly, and that's something that I really think people have to understand. It's not a benign thing to have a toe or a knee or any of those things taken off, because this is something we want to avoid this as much as possible.
It's preventable.
It's preventable.
But the thing, I got to interject, because we're talking about all these terrible diseases, your feet falling, amputations, and kidney failure and dialysis, but don't anyone out there get disturbed to the point you can't do something about it, and something simple.
Well, I don't know. I think, I'm sorry to say, but I think they need a little bit of fear, because what they can't, there was a big campaign with the American Podiatric Medical Association a few years ago. What you can't feel can hurt you. If you can't feel that you have a blister starting, if you can't feel that your blood sugars are elevated, there's a little bit of denial in there.
Well, the first thing I said today was, I have to convince this person who's never had anything wrong that there's something wrong, they're not invincible, they're not as macho as they used to be, it's going to be there, that kind of thing. But I think people are smart. I think if we do a good job educating them that there are some simple things they can do, a few things diet-wise, a certain few foods they shouldn't have.
Few shoes.
And the thing is that, Ray, going back to your initial point, and I think it's an excellent topic there. The gist of the show, or the motto of the show that we've done many times, is positive mind, positive body. That is exactly the theory that everyone should have. Everyone should think that if they have a good mindset, theoretically they should be able to make their bodies feel better as well.
You have control.
Exactly, you have control.
You are in control. And the commercial that the Army has, I love this commercial, be all you can be. Why just succumb and say, I got this terrible disease, and I remember what grandma was like? You can control it. And as you said, and I see this, and Tino does too, we see people who had all close to end-stage renal disease who are now not on dialysis, still doing well. And they've made some changes, a few changes, very easy to make.
I think it's important to point out that we telling people how bad can it be, but what we're actually saying is all this is preventable if you just follow a few simple rules. For instance, I'm sure that the patient that came to Dr. Rates, the patient with a blood sugar of 150, was also 190 pounds.
Correct.
There's
And didn't exercise.
Exactly.
Exactly.
So Paula, let's talk about that a little bit. Now, we're seeing in our present American population, children being diagnosed with diabetes. I mean, this is becoming much more rampant. So, Paul, why don't you comment a little bit of what you're seeing now?
And I think we need to start with education, even as early as elementary school. I think kids need to know they need to get out there, they need to exercise. We need to start with the family, the mom and the parents, knowing that the kids, you can't babysit your kids with a game and have them watch TV so they're quiet. They really do need to get outside. And I know that it's easy to put your kid in front of a TV set or in front of a game, but really they need to get outside, they need to exercise. It needs to be instilled in them, the importance of getting out there and moving and getting their heart rate up.
And that's the problem, is that we have children right now that are being diagnosed with diabetes at 12, 13 years old because of what's been in the schools, the candy machines, shall we say, and lack of exercise. It's important, right? You have a point?
Following what Paula said, think about it. You're talking about educating your children to do the right thing, to exercise, for example. We don't have physical education necessarily in schools anymore. But additionally is eating. How many parents, it's easy to buy something in the middle store in the snack section or something like that. We like something sweet. But right now, think of it. 5 years ago, every soda can that you bought did not have high fructose corn syrup. It had sucrose. Even though it's a sugar, it's not as bad as high fructose corn syrup. So parents should start thinking, as you said, Paula, about not only exercise, but also about what they can feed their children. And we are what we eat, and we can learn to eat a certain way. If we learn as a child to eat better, we're going to have less foot problems later, less kidney problems later, and we don't miss it.
Well, parents have to set a good example as well. If you're in front of the TV, then that's what your kid's going to see. If you're out there exercising, I've done a few half marathons and a triathlon. My daughter's out there. She's 6 years old. She's riding her bike next to me. Mommy's running. I think I'll watch SpongeBob. No, they're going to be out there. You really have to set a good example for your kids with your eating and your activities.
I think that, first of all, they need to be not afraid of knowing that they have the problem. Okay, there was a stigma that diabetics, and nobody wanted to be a diabetic. As a matter of fact, I want to mention that if your doctor is telling you that you're borderline diabetic, get another doctor. You're either a diabetic or you're not. And if your blood sugar is high, you're a diabetic and you need treatment and you need behavioral changes and all kinds of problems. And it's sad to say that I'm not that old, and I'm seeing the children of the people that I saw on dialysis. Why? Because they have not done a good job taking care of these patients, and the patient has not done a good job following the recommendations of the doctor. This is a completely treatable disease that can go on for years and years and years without having many problems. And you know that well because you see people that do everything that they're supposed to do, and they go on and on and on and on. And then the same other person, same age, same body habits, and they're doing really bad. Why? Because they're not doing what they're supposed to. So clearly it's treatable and manageable.
Well, I have a dilemma for the panel here. Let me just tell you, let me throw this out there. An obese patient, obese, overweight, shall we say, comes in who's a smoker, who is also diabetic and hypertensive. These types of patients we know need to stop smoking, but we all know, as working the specialties that we do, the respective specialties, that quitting smoking oftentimes leads to increased appetite. Patients quit smoking, they just gain weight, and this happens quite often. A patient that's hypertensive, high blood pressure, oftentimes related to food intake or salt intake specifically. So when you tell a patient to have less salt, less sugar because of diabetes, and not to eat more because they're not smoking, how do you handle this type of patient? How would you guys take a patient who is obese, smoker, high blood pressure, and diabetic? Well, how do you manage this?
There's a book, The South Beach Diet, Dr. Arthur Agustin, the man who did the calcium score for CT things. He wrote his book, and in the first paragraph of his book, he said, if you follow my book half-heartedly, that's better than not following at all. So I think just like the movie What About Bob, it's baby steps. I tell my patients, look, okay, I can't stop smoking. How many cigarettes in a pack? 20. I said, take one out. For a week you smoke 19. Will you die? No. Will you live? Yes. Will you be satisfied? Yes. The second week, take 2 out. Things like that. In your diet, if you're alcoholic, you stop drinking alcohol. If you're a smoker and you're going to abstain, you stop. But how do you stop eating? Well, what you do is you pick one food. Which is the food that's bothering? White bread. Okay, I won't have any white bread, ever. Big long word, ever.
Correct.
But it works. So now they have whole grain bread. Maybe later they say, I'm going to only have potatoes once a month. Things like that.
And I think, though, important for everyone here, and I want your comments on this as well, is how cheap food is in the fast food restaurants and how expensive whole food or natural food is. How do you convince a patient they need to eat better when they don't have the money, when they know that McDonald's, Burger King, Taco Bell has cheap $2, tons of salt, tons of sugar, but it's satisfying to them? That's the hard thing I feel with my patients right now. Is there any way you guys have gone about saying, how do you convince a patient to eat better, but not necessarily more expensive?
Well, I disagree. I don't think it's expensive to eat well. I mean, for example, a saturated fat costs more than unsaturated fat. A dozen eggs cost $1.50. That's unsaturated. A pound of bacon is going to cost more and be saturated and salty. An apple, the produce section of the grocery store, an apple is still a great food. It's a unit dose. It's disposable. It's got all the things. It's high in carbs, yet it's all tied to the fiber. So apples, berries, and cantaloupe. I tell my patients.
So an apple a day really does keep the doctor away. Is that what you're saying?
It does. It does.
And it is a total lifestyle change. And I think we need to encourage people. Sometimes they make a mistake and they go and then they just throw it all away. They need to know that they can start over again. If they had one bad day, get up the next day and start again.
I usually tell, I'm talking about overweight and whatever, and I usually tell my patients, if it was that easy, I wouldn't look like this. It's a hard thing to do, to lose weight. And unless you do it the way you say, it's not going to happen. You have to do it very slowly because it's extremely hard.
And Dr. Rates, tell us a story about a patient that you've seen has come in obese and they have followed their diet and they have lost weight.
Oh, we bring out the band, the cheering section, the dancing girls. I put our medical software, a lot of medical software has it. When you click vital signs, you can make a graph and you can see that coming down. And I print it up for them and they put it in the fridge and they can actually see what they're doing.
I do one better. When I heal someone at the Manatee Memorial Wound Care Center, I do a cartwheel. I do. I think that's on YouTube as well.
And the other thing is there are applications, like many people have their iPhones and things like that. There's an application called Lose It. And it takes you, if you want to be under 1,400 calories, you can look at it, how many calories, count them up, just click. You go to a restaurant, you can click A for Applebee's and see the entire menu instantly with every calorie and know where you are. It really makes...
and you can put it on Facebook.
It's easy to do. It's really, and there are other things like applications called My Diabetic Pal. Most of these things are free, and they really facilitate a patient's ability to
Empower
get involved and become powerful.
Exactly. It empowers themselves.
Exactly.
Well, guys, I want to talk about one last thing before we close it up today, because I think this is a topic that really is almost a taboo in some circles, because a lot of patients don't like talking about it. It's sexual dysfunction with people who have diabetes. Men oftentimes have impotence secondary to diabetic complications or diabetes themselves. Especially, Ray, when you talk to patients about, they come to the office and have this type of complaint, a lot of times men don't want to talk about this, and they don't realize that it's related to their diabetes.
I think you'll be surprised that that used to be the case 10, 15 years ago. When the Viagras came out, everyone thought we're going to see a bunch of 90-year-old men coming in saying, hey, how about it, doc? You cannot believe how many 30-year-olds and 40-year-olds come in. Now, at first, people would come in and say, I'm here for a physical, my blood pressure and stuff. And by the way, doc, Mr. Johnson, they all call him Mr. Johnson, isn't working quite so well. But
and that's code, folks, at home. So
but the point is, even erectile dysfunction improves by good diet, by watching the sugar, things like that.
And that's important to take. And Paula, you notice that you've seen a lot of people in the rehab that have had the same type of complaints as well. So it's not just one thing. You have to kind of emphasize a number of multifactorial issues here.
And there is a stigma with it. And sometimes, the wife will come and talk to me, or the husband will pull me aside and say, they're having a problem. And I think they need to know that they can talk to their physician, and there's things that they can do. And just like you said, it doesn't affect just the vessels to the heart or to the feet. It affects all those blood vessels.
And the vessels in your spouse. That's the thing that we should understand as well, because these can be a familial issue. It can affect a lot more than just the person. So I think it's important that everyone at home realizes that we're talking about a lot of end-stage issues with diabetes, but we have Ray over here telling us exactly that, if you actually have the positive mind, you can change that body, and that's what's really, really important. So at this time, folks, I think that we're really going to get some closing comments here. So Alyssa, why don't you go ahead and...
The take-home message is going to be to look at your feet every day. Don't just say, yep, okay, 1, 2, 3, 10, okay, got them, all right, good. You want to look at the bottoms. You're looking for any redness, any blisters between the toes. Wear a white sock so you can see if there's been any bleeding. Don't wear black socks. It's not a dye thing. It has to do with being able to see if there's a problem.
Paul?
Take a positive impact on what you can do for yourself. It's healthy living, healthy diet, exercise, get out there, move.
Believe in yourself. You have control. You can take care of yourself.
Tino?
Listen to your primary care physician. Do everything they tell you so that you will not have to see me later.
Very well put. So folks, thank you to all my guests for joining us today. When it comes to diabetes, proper management is the best way to fight back. As always, remember, a positive mind is a positive body. We'll see you next time on The Pulse of Manatee.